get ready to take control of your healthcare. Here's your host, Ray Cobra.
And we're live. Ladies and gentlemen, welcome to Broken Healthcare. My name is Ray Cobra. I am your host, and I am delighted to have in the studio with us today Dr. Dana Mincer, DO extraordinaire. Welcome back to the big show, Dr. Mincer.
Thank you. I'm excited to be
here.
Did
I say Mincer?
I like Mincer. That's like a New York accent.
Mincer. Dr. Mincer.
Yeah. That's like a Staten Island accent, isn't it, a little bit?
Where the hell did I get that? Hold on a second. There you are.
I like it. I'm
Holy
just
crap.
humbled to be here. I love hanging out with you.
I love hanging out with you as well. Everyone puts doctors on a pedestal, and I think that's appropriate because of just the massive amount of work that you have to put in to hold that title. And we learned from you last time, DO is even a notch above, so it's even kind of more prestigious, if we'll use that word. I know you don't think of it that way, but what I love about you is you're like a regular person. In addition to having put in all the work and being the real deal, you're just super relatable. And I heard from many people after our last conversation on air, they were like, she was really cool. I was like, yeah, that's why I had her on. So thank you for being you.
Thanks for having me. I'm just following the higher power.
You are indeed. And I think you're right. My head is in the shot over here. Hold on a second. All right.
Just a little bit.
Technical difficulties. Hold on. Wait, we're going to do this live. This will be a first. Hold on.
This will be awesome. People can see.
Right, so.
I can tell you. I love it. We need to get Tommy down here. He can be our tech guy.
Let's see. Did that work?
It worked.
So I can't do that. See the back of my bald head. I'm going to try to behave. I'll behave over here. All right, we're going to make it work.
You can't do this.
I could do anything. I did the YMCA over the weekend. I could do all that shit. Anyway, we're good. So we got a lot of serious stuff to talk about. We're having a little bit of fun now, but we're going to talk about, you had reached out to me early in the year and told me about a personal experience that you had with a health issue and then with the broken healthcare system. And that's kind of the highlight, the feature, if you will, of the day. But if I zoom out before we get into that story, which is really kind of an amazing story, you're just someone like, hey, Tommy.
Hey.
How you doing, buddy? We don't have him on camera, but
we should put him on camera.
Yeah, poke
Come
in.
here.
Just poke your head in for a second.
My amazing better half.
Yeah, you just kind
don't
of
hit
just
light.
weave your way in. Try not to get killed by the equipment. Say hello. Duck down there. Say hey. Give a wave. Right. So I met these two. At a pool.
Technically, it was the elevator.
Oh, you're right. You tell the story.
You were in this like really hot suit. Like you looked really sharp, but it also looked really hot. And we're like, what are you doing?
You mean sexy hot, right?
Yeah, sexy hot. Yeah. Bald, sexy hot. Yeah. And we're like, what are you doing? We're going out to the pool. You should come to the pool. It's so nice out. And you look like you were going somewhere and you're like, actually, I guess I should go to the pool.
Yep.
And then we met you at the pool.
It didn't take much persuading, folks. It did not take much persuading. And if you've ever been to like a boring insurance conference, the pool sounds so much more enticing than hotel ballroom. I was like, all right, I'm in. I ripped my suit off. I went down to the pool and I hung out with these guys. And the rest is history, as you said. Right. All right, go back, Tommy.
Okay.
Have fun.
You haven't put in the reps to be a part of this conversation.
He's in the background for everything, so he hears everything.
I know, for sure. He's a good man.
Yeah.
So anyway, my blocking is all messed up. I need more subscribers so that I can have a proper studio with staff. But then again, this is kind of fun.
This is so nice.
Yeah.
It's humble.
So we're going to get to your story. Before that, though, just, kind of a topic that everybody can relate to, and I'll share a story with you personally. So, we're here June 2nd. This will probably air within a couple of weeks at this point. But we are probably going to drop an episode this week where I share with the audience my magic mushroom experience.
Oh, interesting. Okay.
Yeah. So I kind of thought about psychedelics for a while, and I'm a fan of the Joe Rogan show, and he's got incredible guests on all the time, and everyone from MMA people to political commentary to people in the healthcare space. And so I heard guest after guest after guest interviewed, people like Aaron Rodgers, who's NFL, quarterback, former maybe at this point. I don't know if he's coming back next season, but extraordinary athlete, but also someone who is kind of a student of the game of health and life. And he described his experience with plant medicine, ayahuasca, psilocybin, magic mushrooms, et cetera, et cetera. And he's had multiple guests on who were war veterans, people suffering with extreme PTSD, people with addiction. And I didn't hear a single one of them say that they had a negative experience. It was all positive, positive, positive. And I was like, all right, so this is something I want to experience. And it's not easy to do because it's illegal. It's you can't, just go out and have a magic mushroom trip. So I kind of went far and wide to have this experience, but I found a great therapist and I was able to do it. And so if you hadn't heard that episode yet, folks, go and check it out. And I wanted to share, what I experienced personally. It's not about me preaching for everyone to rush out and do it. I think you have to be very kind of cautious about anything that you're going to experiment with. Let's use that word. Do your diligence. And I did. I put the work in. I didn't just jump into it. It was a several-month journey leading up to the experience where I went and I had psychotherapy and I meditated and really kind of did a journey inward. I did a lot of prep work. I met with a psychologist and a psychotherapist multiple times, and I was prepared. I was ready. I knew what the experience was going to be, and I could tell you one of the things that I went in wanting to improve was my addiction to alcohol, and it wasn't. I wasn't an alcoholic, quote unquote. I guess it depends on, your definition of that term. I'm sure that some would say, oh, you were an alcoholic, right? But I was, consuming way too much alcohol, totally functioning, but just not feeling great, not feeling the best. And it kind of started ratcheting up for me around COVID. And I don't think I'm alone in that. I think a lot of people, just shut it in place and, it was just easy, accessible, and it's self-medication. Some people may take a little pill. For me and others close to me, it was alcohol, primarily me. I'm talking about myself. And so I just got to a point where I was like, this is too much of a pull on me, and I know I'm not my best self. So I went into the experience really kind of with that as an intention. Let me see if this will help, because it had been reported to have helped people with addiction and with PTSD and stuff like that. And so I said, all right, let's give it a shot. Anyway, you could tune into the episode to learn more about that experience, but fast forward and I'm 3 months alcohol free since that experience. Pretty cool, right?
I think it's so amazing that you're sharing this, and I so appreciate that you're sharing this. I appreciate your vulnerability. It's an interesting arena that people are almost afraid to talk about the addictions that are making their quality of life poor. And they think of it as an embarrassing thing. But from my perspective as a physician who's in family practice, but I've also, I ran an addiction medicine center, outpatient.
Yeah.
I actually find that it's more the commonplace that people struggle with substance use issues. And it might not look like fall down drunk substance use, but for alcohol, I would say it's more the commonplace that people are using alcohol in a way that is intended for medication, or that I see as, we need to fix something spiritually for you. We need to find a different way because you're using this for a reason.
Right.
And so I appreciate you opening up and talking about this. And I wish that I could recommend more alternative forms of medicine for my patients. I have to be careful in that arena because
You have a license to protect.
and they've pulled it before for people. And even when you get it back, then your practice has been ruined. So
Yeah, that's terrible.
Yeah.
You know, that's an unfortunate predicament, because on the one hand, I understand that these entities have a responsibility to safeguard and protect people, right? So that's kind of the guise that they're operating in, and guise is probably a poor choice of words. It's there has to be oversight. I would imagine that, you know, it can't be the Wild West. But on the other side of the coin, why should folks who are really struggling either with addiction or with severe crippling anxiety or PTSD, isn't it equally, if not equally bad, if not worse, than putting them through a system that would prescribe pills and rinse and repeat over and over and over again with, you know, no positive outcome in sight? So the answer is we're just going to have these people medicate, and when the medication isn't working, you know what we'll do? We'll up the dosage. And, you know, it's just, my dentist actually told me years ago, you know, the school shootings, I don't know if it was Columbine or it was the preschool in Connecticut, but he said, I guarantee you that they're going to find that the shooter was on psych meds. And lo and behold, the shooter, it was discovered later, was on psych meds. And I said to myself, oh, my dentist is a conspiracy theorist. And then I started looking at it and I was like, he's right. Like these people, by and large, are medicated. And is anybody looking at, you know, like the parallel here? Is this just a coincidence? I don't think it is. And so it's frustrating to me to hear that a learned physician and student of the game, because you're bold enough to not just kind of say, okay, my education is done. I went through medical school. I got my degree. I know all there is to know. No, you're a curious person by nature. And that's not to say that I don't think you're the type of person, you correct me if I'm wrong, that's just going to kind of spew and regurgitate the latest thing that they hear or do. You're going to be thoughtful about it and do your research. And you have to be wary of giving people advice that doesn't have, is it the AMA or who's the seal of approval that we're worried about?
Yeah, there's multiple different governing bodies. What I do in my office behind closed doors is what I feel like the patient needs. And so that's the nice thing about like the practice that I have now, is that I have ongoing relationships with my patients, and the relationships built on trust and time spent. And so that's a different picture. There is so much clinical utility in ketamine, psilocybin, ayahuasca probably as well. And just because we don't have full data on it doesn't mean it doesn't exist.
Right.
I also like to just put this out there that, you know, when cannabis first became legal for medical use in Pennsylvania, I was really frustrated because it was like the first product that came out was that crack rock of THC. It was called Shatter.
Okay.
One of the first products on the market. I'm like, this is not therapeutic, right? And then we also saw things take a different turn where it's one thing to use a substance as an assistive device to help open up your spirituality or your mind and process things. Because I think, I say this all the time, we as Americans, we get stuck in this talk cycle. It's like you can only talk about shit so much. You have to stop talking about it after that. And you need to figure out different ways to move through it. And I think that your experience shows that that's probably what assisted you in moving through it. So I think there's a utility in that. I also see the other side of some people go all out with these things, and they're like, oh, well, cannabis is herbal, so I'm just going to use it every single day. And that's not good either. That's just replacing one addiction with another addiction in my mind.
Right.
Even if you're microdosing it on a daily basis, I think for most people, not all people, I have a couple people in mind that I know are just like, I think that they're operating on a level that's like so high, their intelligence level is so high that cannabis just brings them down to normal.
Yeah.
But I think for most people, it's like you have to ask yourself, why am I using this substance on a daily basis? Like, why am I not able to calm myself? What is internally sort of plaguing me? But I'm really interested in ayahuasca myself. I'll leave it there.
Okay.
And then we'll talk behind closed doors.
Fair enough. Yeah, it's, and, you know, I had stopped drinking for a month before, and, you know, it's not like I had the DTs or shakes or any overtly kind of withdrawal, you know, symptoms. But there's something about, I think, the experience, and I wish I could, you know, speak to you at a clinical level. I can't, but I feel like my brain was rewired. And I know that, you know, it has something to do with neuroplasticity and, you know, just kind of making connections that otherwise it's almost like just witchcraft. It's just, how does this happen?
So you can speak about it in witchcraft terms, but I mean, while I am a physician, I'm also a certified yoga instructor, and I practice yoga every day, and I sort of view this in an energetic fashion as well, right? Whether you like it or not, we're all energetic beings. Like my atoms and molecules are simply just bouncing around here, and they happen to be like held together a bit more tightly, and that's what makes my structure and my. But then there's all these other interactions that happen, and then in the meantime, by the way, as I'm sitting here with you and having an interaction with you, we're having an energetic exchange that's happening as well. So I like to also just think of it in terms of energy. Like what I see is a lot of times people don't know how to like process the energy that they're taking in throughout the world.
Yeah.
And so I think that having that experience, that physical experience of processing energy different, allows you to then take that experience and apply it to life when you're not using under the therapeutic, I guess, experience, if that makes sense.
Yeah.
I mean, it's why, you know, we have I'm at the end purchase of a Vibroacoustic table that I'm going to bring to the office for all patients to be able to use, because I found this thing and I got on this table and I was like, oh my gosh, this is incredible. It's like teaching, no talk. It's just like we're using sound waves and vibration to teach your body calm. I almost think that that's sort of what happens with psilocybin or ayahuasca, where it's almost like rewiring and showing you
like at a cellular level. And
it's also like specifically with psilocybin and ayahuasca, it's opening your mind to a completely different experience that you wouldn't have otherwise. So different states of consciousness.
Tell me about this table a little more, because I've heard it's just like a flat table, like a chiropractic table?
So sort of. So, okay, I want to start by saying that none of our children are easy. And I would definitely say that my two biological children specifically are probably in the category of neurodiverse. Maybe I am as well. Probably. Who knows? But
meaning what?
Well, like I think that they're hardwired differently.
Okay.
They're very, very challenging. They're not like when you see them compared to their peers at their same age, they are probably about 2 years emotionally developmentally wise behind compared to their peers. And so I had to learn a different approach to parenting. They have trouble calming themselves. They're just like, they're go. Their energy, like they came out that way. Right. And so, I think I was like that as a child as well, and that's probably why I fell into figuring out yoga, because we talked about this on the last podcast that we did. Was I had my own experiences with severe anxiety and depression, and I used substances to quelch those feelings when I was in my younger years, a younger human, I say.
Yeah.
And to the point where it was definitely detrimental to my health. I shouldn't have been using so many substances in that fashion.
Right.
And
you're human. It's and even with your degrees and your learned experience, at the end of the day, you're human.
Yeah, and I didn't know how to process the energy that I was taking in. I think a lot of children or people that are in the neurodiverse category, I would also put them in the super empath category. I realized I was a super empath. So I sense and feel things around me that like other people don't. I mean, you can ask Tommy, like I pick up on stuff and he's like, what? Like, okay, I'm just going to go with it. It's like the feeling that you're picking up on, right? Like, yeah. And I just, I'll walk past someone and I was like, oh, I'm just like, I chills. Like it's just bad energy, bad juju or something.
Yeah.
And so I think that I got on this table just by chance at this fair that we were having at the office. Basically, a therapist, Juliet, brought this table in, and it's you can run different frequencies depending on what the person needs. And she builds these tables out so it's a complete surround experience. So you have a weighted blanket on, there's a small vibration thing underneath you, you have headphones on, you can cover your eyes, and there's even, it's an immersive experience. There's even synthetic or vibratory plates that go over the chakra areas as well. And I got on and I was like, oh my gosh, this is calm. This is what calm feels like. And I know this because I work toward this with my daily yoga practice and breath work. And I called Tommy and I was like, Tommy, you got to bring Stella over. She's our youngest. You got to just bring her over. Like, just, she was the one that we had at the time. And put her on the table, and she's 7, and she just went like, wow.
She went in.
And we had to pull her off after 10 minutes. And she's like, no, I want to keep going.
That's how I felt after my last colonoscopy when they woke me up after giving me propofol.
Yeah,
I was like, put me back.
That crap burns going in though. It's so good. So that's the difference between if you can get the same effect from something that's not as invasive, I would say, toward the body, right?
Yeah.
Teaching the body calm. So I mean, come
That's
down.
wild.
Once we get it all set up, I have this amethyst biomat that goes underneath, and Juliet just texted me, I think last night, that the full table's ready because she builds these tables out specifically. I'd love to have you come down with your wife, try it out.
I'm in.
Or I can bring it up next time I come up. It's portable.
Wow, that's awesome.
Yeah.
Yeah. Well, and that's an example, I think, of what is possible when you're a physician that is operating outside of the status quo. Right? Because how many docs really have the time even to explore stuff like this? And then if you are a traditional doc and you're working, for the local hospital system, they don't want you doing stuff like this because this is going to cost them revenue. Right. Well, maybe speak about that a little bit. Is what I'm saying the truth, first of all, because lots of folks that I think tune in, listen, and they're like, well, I have the best healthcare possible, pick a flavor, United, Aetna, whatever it may be, Cigna. They think the logo on the ID card kind of, drives what is and is not good healthcare. And then beyond that, it's typically a doctor that's affiliated with a big hospital system. That's the next badge of honor that's going to have them beating their chest saying, oh, my insurance is better than yours and blah, blah, blah. What do you see? I mean, first of all, do you think is that the pervading opinion, or do you think, I'm off there?
No, you're not off at all. You're not off at all. I think it's a really complicated answer because I think it's multifaceted.
Yep.
I think that it just like when you work for any employer, any large employer, there's rigidity, right? I mean, we're entrepreneurs. We're all entrepreneurs here. We have a cleaning business in Richmond that we bought, and we're, and so as companies are small and tiny, they can pivot and they can try out new ideas. And if the owners are involved, and we can, make decisions a little bit more on the fly. And I think as companies in general, this is just general rule of thumb, get larger, that unless you put certain ways of doing things in place, then that tends to happen. As companies get larger, they get more rigid, they put more policies in place and standards of care and this and that. And so I think that's part of what has happened with the consolidation of the health systems. The other thing is they just want to be able to bill insurance. And so this is not an insurance billable item. And so why would they spend time on it, right? I think the last part of it is that this is just a general thing that's not considered in Western medicine, energy work. Like it's just not the normal. When you talk energy work to standard Western physicians, most of them are just like, ew, go back to evidence-based medicine. What's wrong with you? You know, like,
Yeah.
but they are also quick. A lot of patients come in and complain that they're quick to be assigned, this is psychosomatic. My stomach issues. He wrote in the chart that this was psychological for me.
Okay.
When they don't know an answer to something, which I don't know if it's generally that far off. I mean, maybe it is, but I think it requires more of a conversation than that.
Yeah.
So I don't know. I try my best not to like go into situations and be like, these people are evil, right? Like I try to give people the benefit of the doubt.
Sure.
The same thing in the brokerage space. I think we had this conversation before. Like, I don't think that the standard brokers out there who are only selling Blue Cross, United, Cigna, and Aetna and are evil. I think that a lot of them, maybe they don't know a different way.
Yeah.
Or they just, I mean, you can talk more on that. And then I think and they're incentivized to not know a different way. But a lot of times once they see it, they're like, oh, and then you can't, how do you go back?
Well, here's the issue. The average broker's tenure is 6 years, meaning that's the client-broker relationship. Same broker for 6 years, doing a bad job, right? And what do I mean by that? Bringing the client increase after increase after increase, playing the shell game of raising the deductibles, raising the copays, transferring more of the out-of-pocket expenses onto the employees and members. It's 6 years. And why is that? Because as in any other facet of business that we do, it's relationship driven. And we're talking about big spends, right? So generally speaking, our focus is mid-large enterprise market, talking about millions and millions upon millions of dollars being spent on this. And you might say, well, Ray, that's crazy. Why wouldn't they put this under a microscope and, really examine, do a forensic deep dive and figure out a better way to do this? And the answer is as old as time. It's relationship driven. It's trust. So I agree with you. It's not that the brokers are evil. The brokers who are the face of the brokerage are genuinely great people. Go to games with them, hang out, restaurants, fine dining. They could be your best friends. The disconnect is they are only bringing their clients the options that are decided in the boardroom. So at the CFO and the CEO level of the large privately held brokerages and the publicly held brokerages, they're about one thing. They have a fiduciary responsibility to their shareholders, not the policyholders. And so they are perfectly aligned with the big insurance carriers, and they're not going to adopt a strategy like the ones that we just discussed if it means cutting revenue. Because if they're cutting revenue, then they can't fulfill their fiduciary obligation to their shareholders.
Right.
And that's where the problem is.
I mean, it's identical in medicine.
There you go. Right? Exactly.
With the physicians. Right?
100%.
It's the same. It's a very similar situation. Just, the incentives can be a little bit different depending on the system. But I would say, and this might be bold, but most of the health systems nationwide are for-profit organizations masquerading as nonprofits. And I'm just going to let that sink in that, I wrote an article on this about Abington, Jefferson specifically, which is the health system in our area in Philadelphia, one of the major ones. And we live right around the corner from Abington Hospital, and there's just beautiful haven of a hospital that I trained in, even with my straight Western medicine training. Like, it was just this high quality care, great specialists during training, and then Jefferson came in and bought it. And they're not paying taxes in our community. Like, they're not paying property taxes. My children are in the public school system, and we need a new middle school. And so they're raising everyone's taxes, which is fine. I'll pay it. I don't even care. It's fine. But I know some people are struggling and it's difficult for them. Meanwhile, this huge Goliath of an entity is like not paying any taxes. And then, they're anyway, it's just a frustrating corporate practice that's happening. And again, I don't think that what you said is much different than what's happening sometimes with physicians but we call it, is this evidence-based medicine? And then we have organizations that make protocols for things. And if you don't follow those protocols and something were to happen and the patient wanted to, or the patient's family, like they don't have a relationship with you, you can get sued. And so, did you deviate from those protocols or not? I think it's a little bit more complicated in medicine because of the liability factor. And I understand why physicians are a little bit less willing to deviate from like the standard of care protocols. But it is also very similar.
Yeah, no, without question. And I agree with you. I think the nonprofit status that 95+% of these entities enjoy, it's a loophole. Call it what it is. It's a loophole that really should be closed. We talk about politics, ad nauseum, right, left, this, that, tax the rich. How much taxes would we have as a nation and the individual states if these entities started paying their fair share of taxes? It would be a tremendous windfall. And I understand that, there's certain,
if they're utilized correctly.
If they're utilized
That's the
correctly.
other half of the battle.
Yes. I would go on the record as saying, let the entities keep the money and spend it wisely, as opposed to, having it fall into the hands of our federal government or our state and local governments. That's a conversation for another day, right?
Yeah.
But I think the disparity, though, is should XYZ for-profit corporation pay their fair share of taxes when these other entities are essentially for-profit entities who are, basically just riding on their coattails, the coattails of the for-profit entities, and not paying taxes. Like, that's no bueno.
And that's a reason. This is one of the prime reasons. I mean, not all the reason, but why I decided to come out and like with some of this information in the hopes that it would help to bring, I'm 100% committed to transparency.
Yeah.
So that's how we're going to fix the system, is through transparency.
Yeah.
But that's also how we fix most things. That's how we fix our intimate relationships, transparency, right?
Yeah.
And presence.
Yeah.
And so that's part of the reason why I was like, I think that we should test this sort of pilot episode out to talk about and make these things more transparent with hospital billing practices. And what better way to do that than through actual real cases in small amounts, so that people can wrap their heads around what's happening, right? And they can really understand that the $4,000 MRI is a real thing that's happening.
Yeah.
When it really should be $450.
Yeah. No, and we're going to get to that in a moment. I think that the last thing that I'll share personally is, for about the past year, I've broken away from the traditional system, and I have a direct primary care physician, and so I told him about, my magic mushroom experience and all that. And he said, "Can I get her number?"
Awesome. Good. I'm glad.
And so, but I told him, I really don't feel the urge to drink as I did. I said, and I don't know if that means I'm never going to drink again, or, because for me, it was really just about, it was most definitely a habit. I'm not going to sugarcoat that. It was a bad habit.
I mean, we're creatures of habit.
Yes.
Whether we like it or not.
But it was also just kind of the way that I would wind down at the end of the day. It was a social kind of mechanism. Any brokers out there listening will tell you that deals get done at the bar, not in the boardroom. And so it was just a way of life. And I said, I don't know if it means I'll ever drink again. And he looked me dead in the eye and he said, I don't think you should. That was pretty cool.
Yeah, it really is toxic, I think, in the way that people are just, I always say the same thing to people. We like to think that our brains, and this is just from all of the research I've done in the realm of positive habit coaching, we like to think that our brains are so much farther developed than animals, and they're not.
Yeah.
They're really just not. We are creatures of habit. We have animalistic brains still. And so I think that just the simple purposeful act of bringing consciousness to, what am I doing right now? Am I doing this out of habit? Am I doing this because I want to do this? Am I doing this? Am I present in the moment? Like, just consistently asking yourself those questions in the moment can help with that as well. Like, why am I picking up a drink right now?
Yep.
Am I picking up a drink because it's a social thing and there's a glass of wine that was poured for me? Or am I coming home and I'm having a glass of wine or I'm having a cocktail to relax? And if that's the case, I always encourage my patients to say, what are the other ways in which you feel like you could relax? Could we get you to do a 20-minute yoga before you come? Like, just put a video on, do a 20-minute yoga stretch. So that way you're physically releasing energy from the body, you're stretching your muscles, you're opening your joints up. And that will actually change your brain chemistry as well. And then reevaluate after that if you actually feel like you need the drink.
And so that's awesome advice. But I know that there are people listening out there, as I am, that are like, the glass of wine just sounds so much better.
It's okay.
But yeah. No, but you're exactly right. I mean, there are different ways to perform stress release, and you might want to give it a shot because, and it's true, man, after like a rigorous workout and yoga, for those who are not indoctrinated, can be extremely challenging and vigorous. And at the end of a quality yoga session, I'm sure your body releases endorphins, your brain releases endorphins, you get that kind of athletic high, right? But it just all depends on the practice.
Yeah.
But I'm with you. Like that needs to be the go-to as opposed to that bottle of bourbon. At least
I also
for me.
think it makes you more present, right? Like I think all of these situations give us opportunities to train our brain, which is a constant process, right? I like to think that my brain is never done being trained, and it's got to train and adapt to different circumstances. And I like to think that if you're coming home and handling stress by having an external substance that sort of just numbs you, how is that going to help you in functioning when you have stress with your partner or when you have stress with your child, or your boss for that matter? You can't just like numb yourself in those situations. You need to actively engage. And so if you can teach yourself to be what calm feels like despite any external circumstance around you, and it's not 100%. Like I've been at this yoga thing for decades, and you can ask him, I still lose my shit from time more frequently than I would wish. And I
By the way,
appreciate that he really works hard at staying
Tommy
calm.
just like gave a sideways glance. Nothing overt, but I caught it.
So like, I think that it's a constant practice, right? And but I think that what I notice, and just from doing it myself, and then also from, because I practice what I preach, and also from just having patients come back and talk to me about these things, is like, I can see that it's like this calmness is infiltrating in a positive way the other aspects of my life too. Right? Like, I say the same thing with the workout. People say, okay, well, I couldn't get to the gym, or I couldn't do this. And we had talked about this earlier. Like, what if you just set 20 minutes, just 20 minutes a day for my movement? It can be any movement. Like if I'm feeling tired today, it could just be a calmer yoga practice, but I'm just making 20 minutes a day for me and my movement. And I think that as you become consistent, that consistency and that calmness and that focus translates into other aspects of your life as well.
Yeah. No, and I think it's, the other piece of it for me was wanting to dial in fitness and nutrition. And the way that I thought about it was like alcohol is the number one. That's most important. Like if I'm going to check boxes, that's kind of the box that I want to check first. And then, unfortunately, I kind of found myself eating ice cream every night, and just
I love ice cream.
Going to exactly
every night,
just going to a different vice. Yeah, but that's not good either, right? So
well, hold on. You could get, this is a suggestion.
Okay.
Do you like mochi balls? Have you ever had mochi?
No.
Is there a Trader Joe's around here?
We have there probably is. There's like
an
Costco
organic.
and
Is there an organic? Is
Whole
there Whole
Foods?
Foods?
Yeah.
They probably have mochi balls. I suggest this if you really love ice cream every night, because if you just cut yourself off, that inner child in you is going to be like, right? Because I always tell people the same thing. You can't cut yourself off, because we all have this inner child in us, whether we like it or not. It's in there.
Right.
That's actually what drives a lot of our troublesome behaviors still as adults, right? The inner child that we don't want to acknowledge. But if you could just get small sample sizes, and I like the mochi balls because they're like, it's like this big and it's got ice cream in the middle and sticky rice on the outside. They're really delicious.
Really?
Yeah. Or if you can find
So it's a little fix.
It's a little fix. And you teach yourself to work through it slowly.
So you don't have 200 of these.
You don't, no. The idea is no. Some people have trouble with just that limiting factor at all. And in that situation, I would say then just don't bring it into your house. You make yourself go out for ice cream.
Right.
That's it. I mean,
Right.
But if you feel like you can be a little bit more controlled with it, it just depends on your personality. Those little single serve things are perfect for that. And then you're not limiting yourself, because when you limit yourself and you're like, no, I can't have this. Then once you have it, you're like, I'm getting a double extra large with whipped cream and cherries and caramel and chocolate and everything.
I want 6,000 calories.
Yeah.
That's the one I want. Yeah. I mean, for me, so I don't know if you're familiar with the Scarsdale diet.
No.
So
but is it from Scarsdale, New York?
Scarsdale, New York, Scarsdale diet. It's a 2-week program. And essentially what you do is there's a set menu every day, breakfast, lunch, and dinner. Breakfast is the same every day. It's black coffee and a half a grapefruit. Lunch is typically varied, and dinner is typically a protein, like you could have lamb or beef or chicken and like steamed vegetables. And if you want a snack, you could have celery and carrots. If I stick to that diet for 2 weeks and by the book, no sugar, no processed anything, I'll lose 20 pounds in 2 weeks. And then the problem becomes, well, then you can't go back to what you were doing, because if you go back to what you were doing, it's kind of like you're just going to put that weight on and then some, right? But for me personally, the one common denominator in me packing on weight is typically bread. It's anything having to do with bread, pizza. Though that seems to me, and I know that converts to sugar as soon as it hits your bloodstream. If I eliminate that and sugar, the weight seems to fly off of me. It's just the challenge of, okay, how do you get an older Italian raised guy who is surrounded by bread and pizza and pasta to eliminate that stuff? But I know that if I do, it will be, I'll probably drop 15 points on my BMI.
So that's an interesting concept that you brought up, right?
Yeah.
I think that some of that comes from also just, I don't know if you heard about this, but in the 60s, they significantly genetically altered the types of grain that are grown in the U.S. Do you know about that?
GMO?
It was like, I don't know if it's all just GMO or the actual strains of the wheat that's grown is different from the original ancient strains, such as einkorn. And there were a couple other, and I'm blanking on the names right now. So I actually finished my university, a small American university in Switzerland. And so I lived there for a couple of years. And that's the Italian part of Switzerland. So it's a lot of Italian culture and food. And I don't know whether so for some people, it's just quantity. Like they feel like once they start eating carbs, they can't almost stop themselves. They can't just have like one slice of pizza and a salad. They eat, But in Italy, it's common that when you go out to dinner, you go to a pizza shop on a Sunday night and you get it's a thin crust in the north at least, and it's a pretty decent sized pizza, and you actually eat it with a fork and a knife. Yeah. And so I don't know how much of that comes from just the fact that this grain has been genetically modified, and that's what we're now calling our gluten our carbs here.
Yeah.
And then some of it might just come from people just love carbs so much that they just want to, eat carbs. I don't know, but
more studies should be devoted to that, because really if our food supply is poisoning us.
I mean, a lot of it is like that's all the whole concept with how in God's name do we still have synthetic toxic dye chemicals in our food, especially in our kids' food and in our cereals. Like they already made the red dye, what was it, red number 40, illegal finally in the US. But like, none of these dyes have been legal in Europe. And I don't know whether I think it's an American thing where we're so tied to our freedom.
Yeah.
Right? I will ingest sewage if it means that I am free.
Well,
right? It's like, it's almost, I know that's an extreme version of
there's
it.
that,
but
Dana,
it's,
but then there's also
we don't want the government telling us what to do. But at the same time, oh, you brought it up for, look, we have a
Wait,
fact checker.
This is our Jamie.
Yes.
Thanks, Jamie.
Okay, hold on. Hey, to understand what was, let's go back to the grains real fast. And then I'll come back to that. To understand what was introduced to grains in the 1960s in the U.S., consider the following points. How do you say that? Glyphosate, right? Glyphosate. An herbicide was first registered for use in 1974, not in 1960s, okay? In the 1960s, the use of synthetic fertilizers and pesticides increased significantly. There was a green revolution which introduced high-yield crop varieties and chemical inputs to boost grain production. But was there anything used with? Did you find anything about the genetic alterations of the einkorn variant? We'll have to come back to that. Yeah. Anyway, but I think so.
Thank you, Jamie.
Thank you. But I think going back to the freedom portion of it, in Europe, none of these things have been legal, and I think I'm not saying okay. I experienced the socialistic healthcare system because at the time I had a boyfriend there, an Italian guy. He got into a horrible motorcycle accident, was getting skin grafts in the hospital, and it was like it's not a hospital where you want to be. Even in Switzerland, you don't have any private rooms
They don't
unless
have
you're
the
paying
same trauma
for private
care.
It's just a different system.
Yeah.
Let's just put it that way. I don't know that most Americans would be happy with that system. And there's long waits, especially in Italy, for just getting into any care. I have a friend who's a physician there in outside of Lake Como, and she's just as miserable as the American physicians are with the schedule and everything.
She has better coffee breaks, though.
Yes, probably. They have better espresso.
Just the views.
Yes. But going back to that, I think that Americans would be really upset a lot of Americans already are really upset that the government came down and said, okay, well, we're making this substance illegal. I would say we should just make all toxic petroleum-based dyes illegal. And there's a bunch of other things that we should be making illegal as well.
Sure.
But that infringes upon our freedom as individuals and also economically because these companies have made entire structures based on these chemicals in their foods that they're producing.
Ban it all and ban it immediately. That's not freedom. That's oppression. It's the opposite of freedom. Why are there less than 400 substances approved in European products, and there are over 10,000 such substances approved here?
Well, that's the
10,000 to 400.
Yeah, that's the positive side of the socialistic healthcare system because the government is essentially paying. Switzerland's a little different. Switzerland's a semi-private system. That's a story for a different time.
Yep.
But at most other areas in Europe, that's the one positive outcome is that, hey, we're the government and we're paying for your health. So we better figure out what else is going to do you harm in your food products, and those are not going to be legal in this country.
Yeah, no, and that's one of the things that I applaud Secretary Kennedy, for doing. At least he's trying. But as you can imagine, you have the giant insurance carriers, you have the PBMs, which they own, you have the institutions themselves, the hospital systems, you have private equity backing all of that, and then you have big food. And you're talking about trillions and trillions upon trillions of dollars of organizational revenue that is at risk. And you have Secretary Kennedy, kind of waving a white flag saying, we got to stop this. And, we've already kind of seen Dr. McCary get the boot. Is Secretary Kennedy far behind? Probably not, because I hope that's not the case, but probably not. And, why not? Just because he's going against the grain. And when you have that much money at stake, it's just that you could just see the writing on the wall. It's like his days are numbered. But God bless that man for, doing the work that he's doing, because I don't think anyone could point at what he's doing other than, just kind of the bullshit vaccine, anti-vax spin that the media is putting on his take on things.
Which is not true.
Which is not true.
It's not true.
No.
There were certain vaccines where he said they shouldn't be part of the regular schedule. But I'm going to get massacred by my medical community for like saying, now you support Kennedy. And I'm like, no, that's not actually true. I like to evaluate the individual things that people do. That doesn't mean that's who they are as a person. And I agree with you. Anyway,
I'm glad that you said that. No, but the truth is, at least my understanding is that he's not an anti-vaxxer. He's pro-knowledge. In other words, the people have a right to know what they're putting into their bodies. And a lot of this stuff was kind of fast-tracked without understanding the full risk.
A lot of it was fast-tracked.
I don't think anyone could disagree with that. And so, but he's being eviscerated out there. Anyway, I think I think he's an American hero. I've gone on the record as saying that before. I continue to believe that. I think he's a true American hero, and thank God for that man. But anyway, let's get off of that soapbox.
You should tag him in this.
I will. He'll never see it. Him and my 4 listeners will probably see it. I don't know.
You never know.
But yeah, I love that guy. Anyway, let's fast forward and transition now to your personal encounter with the healthcare system as a patient.
Yeah.
So I get an email from Dana right around the turn of the year, I guess. I don't know, it was January, what the exact timing was. And you basically said that you had a slip on the ice, and I wasn't even sure. And you were all fired up about something. So let me just kind of let you take it from there.
Yeah.
But this was a woman on fire. So yeah, tell the audience what happened to you.
Yeah, so I almost was hesitant to bring this in as like my case because this is not about me. I realized quickly, and this was the same thing with the DPC where I was like, okay, I need to get out of insurance-based medicine. I'm going into DPC and direct primary care, and then I realized quickly this was larger than me. So I realized quickly this was an opportunity. I had a small break in my arm. It's not a big deal. We were ice skating. I got pulled down, slipped on the ice. I had but I wasn't even in a cast, but it was after hours. There were no urgent cares open in Williamsburg, Virginia. And so I couldn't really move my hand, and I was in a significant amount of pain. So I knew it was broken. I just was like, I need to sort of just know, is this a comminuted fracture, meaning like, do I need surgical intervention or not? And the only place I can get an x-ray right now and get some pain control is if I go to the emergency room. So we show up at Sentara Health in Williamsburg, and I had maybe a 5 to 10 minute visit actually with the physician. We had all the kids with us.
Oh,
it's like 11 o'clock at night by the time we get. And I just needed 2 x-rays. So I needed a forearm x-ray because the way that I came down, I don't know if you can see me in camera, but I came down, I went backwards and I hit this against the ice. And so there's a common fracture that actually can happen in the radius. Thankfully, I have really strong bones.
So you kind of went down on your left elbow?
It slammed against the ice here, but I actually fractured the head of the radius, which is up in this area. So it was like the force went through
like a shockwave.
My olecranon, which is the elbow, and but a small fracture, but it was right where like the tendon is, and so any type of movement was just extremely painful.
Yeah.
I also probably hit the ulnar nerve there, and that was what was causing the difficulty moving my hand. So I just knew I needed x-rays. So you have to get a forearm x-ray and an elbow x-ray because there's 2 separate x-rays. And I have a health sharing plan. I love Zion Health Share. I've had them for years. And so I'm not worried. I know I'm going to pay my first $1,000, which I elected out of pocket if it comes to that. And then I'll be okay. Thankfully, thank the universe that I'm not struggling in that regard.
For the audience that doesn't understand, and we've mentioned it on the show before, Zion is not insurance.
No, they don't qualify as insurance. They're a health sharing plan. And health sharing plans are great options for people that are otherwise healthy. I'm more than happy to have conversations with anybody and everyone about this, in fact. And I love to do an apples to apples comparison. What I like to say is, hey, listen, for your family personally, look at the last year or even 2 years.
Yeah.
Write down everything that you had in healthcare. Like, did you go to see a specialist? Did you go to urgent care, and how many times? Did you have an x-ray done? Did you have and then we can do an apples to apples comparison to see what that would have cost you, self-pay. But I'm a huge fan of the health sharing. There's Zion Health Share, there's Sharewell Health. We also work with Health Access Solutions. Tommy sort of helps people to go through him for that.
Mm-hmm.
So for otherwise healthy people, I think they're really great options. And I was scared out of my mind when I first took the jump like 7 years ago
Yeah.
because of all the brainwashing. Like there was really actually no reason for me to be scared because I've been through a hysterectomy with them now. I've been through a broken arm with them. I know they're going to pay. I pay the first $1,000 of my incident and then I get to choose. There's no network. Like
Yeah.
they kick in and pay the rest. Sometimes it's after the fact. So I pay up front and then they just reimburse me. But I've never had any issues. So I just want to throw that out there.
No, that's really cool because a lot of people, as you say, are brainwashed, right? You're a physician.
I was brainwashed. We all are. That was the purpose of that was the whole that's a whole big strategy for the last 40 years is brainwashing us, price fixing, price inflation, artificially inflating prices, and scaring us into submission.
And so what Zion does and other health sharing organizations do is you pay a monthly fee, the same as you would for an insurance policy, which is regulated by the state. And Zion and none of the other health share services are regulated by the state. So people should understand this and do their diligence and do their research. But at the end of the day, instead of kind of being, death by 1,000 paper cuts where you have a copayment and a copayment and a copayment and a copayment and a copayment, and then, you have these other maybe large lump sum expenses for emergency visits, et cetera, you simply have a deductible with a health share organization.
You can't call it a deductible, though, because it's not an insurance plan, right?
Essentially, you have...
They call it your initial unshareable amount, the IUA.
The IUA, there you go. Yes, you have an IUA, and that's not a sexually transmitted disease or a contraceptive. It's an IUA. Yes, it's your responsibility of the cost, your share of the cost, and then after that, they pick up the rest. And there are limitations and rules surrounding that. You can perhaps trigger a second IUA, but at the end of the day, when you look at it, it's pretty friggin' cool.
Yeah.
And, in terms of what you're getting. And when I think about the broken healthcare model, I think that's by and large a big problem of the disconnect is the way that we've designed our insurance policies, or I should say the way that insurance policies are designed so that we're treating healthcare kind of like a Pez dispenser. You shouldn't need an insurance policy for a trip to the gas station to fill up your car, right? Trip to the gas station to fill up your car, this is it's not even routine maintenance, it's just part of what's needed. And so you should absorb 100% of that expense, right? That's logical. But we are kind of treating our health insurance policies are treated, and the gas station is a bad analogy maybe, but you don't have an insurance policy for an oil change. Exactly. You're going to foot 100% of that bill because you should.
That's a predictable cost.
It's a predictable cost.
Insurance is for unpredictable costs, but it's not for predictable costs.
Yep.
That's the basis of insurance, number one. And so the issue is that the insurance industry for the last 40 years has made everything seem unpredictable because they price gouge, they artificially inflate prices, which scares people. They don't allow physicians and systems to publicize their prices. Actually, written into their contracts, they have silenced physicians and saying you can't publish your self-pay costs because we have a contract with you. So if you want to get paid by us,
right,
for all these Blue Cross patients, right? And so they've made it seem unpredictable and what transparency does is it makes those costs predictable again. So with full we now have full networks. Even just locally, I have networks of what does imaging cost, what do specialists cost, what does a bundled orthopedic surgery cost look like for a full knee replacement start to finish, specialist visits. We have all these numbers now, and then you can do your apples to apples comparison, and possibly you might find that you just want to insure for the unpredictable. If I have an accident, God forbid, or if I end up in the hospital for something, and that's when my major insurance kicks in. Or if I have any incident like a kidney stone that requires a small surgery to get the stone out, that's going to end up being more than $1,000 or $2,500, whatever you elect. And
Right.
then my insurance will kick in because that's unpredictable.
Right.
But I'm budgeting maybe up to $2,500 per year. I'm going to just put that money away and save it.
Right. And instead, the average cost of an insurance policy, according to the Kaiser Family Foundation that's sponsored by an employer, is now $18,100 a year. So $18,100 a year, I think most people would probably consider that a catastrophic expense. And that's the baseline for an insurance policy that is meant to protect against a sudden, unpredictable event.
Yeah.
And
We're going to
so-
have I have a separate presentation I put together on this. And this is thanks to a good friend of mine, Chris Barakat, who has been an awesome mentor. And just we're going to end up, if we don't do something about the situation, we're going to be in a situation by probably 2035 or 6 where the cost of premiums for a family are going to be over half. And that's just the premiums. That doesn't include copays. It doesn't include your deductible. But it's going to be over half of the annual household income, 50% of the annual household income. Who's going to pay that?
Yeah.
It's going to be a Medicare for all. Maybe the really wealthy people just deal with it, or I don't know, they do something else. But like, we're in a catastrophic situation right now. And the way to change that is through price transparency. And that's why I wanted to do this, even though, I'm exposing a large health system and a system that they contract with, Williamsburg Emergency Physicians Incorporated.
Every year, July rolls around and someone's scrambling to get PCORI filings done. Spreadsheets, emails, stress. Simple 720 automates it in minutes. They're an IRS authorized e-filer, so everything is filed electronically and sent straight to the IRS. Fix it before the deadline. Simple720.com. All right, so let's get back to the fall on the ice. So you're skating around with your family. You're a good skater.
I am a good skater,
You're a good
right? Tommy, tell him I'm a good skater. I got pulled down. It was my fault. I was
Okay.
lending my hands, and I was behind me to a tinier
You were
human.
showboating.
Yeah, I'm a pretty good skater. I'm not like amazing. I don't do like triple axles or anything, but
Right.
we're both athletic, so
Yeah, you have good balance, coordination.
So, but you don't see it because they're behind you, and then they go down like and they pull you down. And
Yeah.
big enough to it was my fault. I should have been like, no, you're not holding my hands from behind, but I'll skate backwards and
Right.
hold you that way.
Gotcha. All right. So
anyway.
so you go down.
Yeah.
You have this kind of this ripple effect that actually does more damage, not where you impacted, but above it, if I'm
Yeah.
understanding you right.
Yeah, and I couldn't really move my fingers very well, so I needed to get an X-ray, and I needed like some tramadol, just 1 or 2 pain pills to get me through the night because it was really, really uncomfortable.
So take us through. How far are you from getting emergency care?
Not far. I mean, it was 10 minutes.
10 minutes.
Everything's close in Williamsburg.
10
'cause
minutes.
Yeah.
You're like, hey, this is not good. Got to go get
Yeah,
it
and we
checked
live
out.
down there. I hate to say that we met long distance, just as a reminder. Like, it's not like we have a vacation home. No, I'm not balling in cash like that.
Right.
But when we continue to be long distance because we have kids and exes on either side, so we go back and forth. So that's like a familiar area for us. So
Yeah.
we're like, hey, what's open?
Meet in
we
the
got to go
middle.
to Sentara. That's what's the closest thing is. So we roll up there. They take me back. I get the 2 X-rays, and then I look at the X-rays myself. I mean, I know most people can't do that. I was like, okay, I see the chip. There's a chip. It's broken. This is why I'm in pain.
Right.
But I see the physician assistant. Now, Sentara is just the health system, and they are a for-profit system. Sentara contracts with, and I found this out afterwards, Williamsburg Emergency Physicians Incorporated, which is called WEPI. And all that means is Sentara is sort of just like the physical structure. I think they own the X-ray machines. And then WEPI is the emergency physicians group. And they employ the physician assistant who saw me. I never saw a physician. I just saw the physician assistant, which is totally fine. He's more than capable of handling my small fracture and handing me a tramadol to go home with. Like,
Yep.
no problem.
Yep.
And that's it. It's just like a 5 to 10 minute visit. They gave me this crappy sling that really, they didn't even, with this type of injury, they actually want you, it's really uncomfortable. They want you moving it as quickly as possible. So like not even in cast or anything. It was a very simple thing.
Did you spend any time, getting triaged, and or was it pretty quiet night? Was this New Year's Eve?
It was New Year's Eve.
Surprised it wasn't more jammed.
Well,
but,
it's Williamsburg.
Okay.
Yeah.
Yeah.
Like people, I think there's a lot of retirement folks that will go down there, but I mean, we waited a little bit of time. It wasn't a ton of time. No.
Okay. So you were seen relatively quickly.
Yeah, it was pretty quick, right? Yeah.
He spent 5 to 10 minutes with you? 20 minutes?
The PA was maybe 5 to 7 minutes.
5 to 7 minutes.
It was a quick, just like, I think it's fractured too, and the radiologist will follow up with us, and yeah.
So your whole visit, start to walking through the doors till getting out of that place, how long were you there?
Probably an hour.
An hour.
An hour and a half max, because we were waiting a little bit, but...
Yeah, not bad. New York City, it would have been 3 hours.
Right. I mean, at Jefferson by us, it would have been a 12-hour visit.
Yeah.
That's how bad it's gotten.
Well, there you go. So 12 hours is probably more on the order of what it would have been here.
I mean, I worked up at the Bronx in the ER there. That was a
madhouse.
I would have been 2-day wait.
Yeah.
Yeah.
Yeah, exactly. Okay, so they send you on your way.
Yeah, and they're just like, follow up with ortho. I'm like, yeah, thanks, I don't need ortho, but, any other person probably would have. But I'm going to call my awesome friend Mike, who's the most amazing physical therapist.
Right.
And just get him to make me whatever I need to do.
So
rehab it.
what was the kind of the exit orders? Is it like take Motrin or...
Yeah, that's it. Just like, hey,
ibuprofen.
wear the sling for now while it's painful, and then you're supposed to start to move it as quickly as possible, even though it's painful. And
ice and cold and alternating and all that jazz. The usual stuff.
I think they gave me. I was like, listen, I don't do well with opiates. Can you just give me 2 tramadol? I just need the pain control to get through tonight, maybe tomorrow night, and I'll probably be fine after that.
And that was that.
Yeah.
Okay.
Mm-hmm.
And so when does this is pretty routine so far. I'm not hearing anything crazy unusual.
Yeah.
When does it become a story?
So when we got the bills, I mean, that's it. So the bills rolled in afterwards because I roll up with the health sharing, you say I'm self-pay. Mm-hmm. Just off the bat. You don't even bother. I think there might be some other health sharing companies that might, but you get them all confused if you try to start looking it up as insurance and it's not. And then the bills roll in afterwards, which I was expecting. I knew things were inflated. I was not expecting this degree of inflation. Let's just put it that way.
Right.
And I was not expecting like the no options for negotiation.
So knowing what you know in your brain, what were you thinking the bills were going to be?
I don't know. I was thinking maybe for the visit itself, they're probably billing as a level 4, which it shouldn't be, but just because they're in the ER, they can. Which for people that don't know this, we bill medical visits as level 1, level 2, level 3, level 4, level 5. Level 5 is like I'm coming in and having a heart attack coding, but usually they'll try to get the most out of billing because that's what they teach you in med school is you need to maximize the way you bill so that you bring in more profit, right?
Yeah.
And they don't think about the patient in that regard. They're thinking of it in terms of insurance.
So those levels are categorizing the level of trauma?
Yeah, or like the degree of, and you can bill by
severity.
time as well, severity. But now we have time billing. So if it's between, 0 and 10 minutes, it's a certain time frame. And if it's up to 45 minutes, it's a different time frame and, all of the above. And so just because it's in the emergency room, they usually try to get away with billing a level 4, which it shouldn't have been because it's really not an emergency room visit. It could have been handled as a level 2 or a level 3. So I figured they would probably be in the range of like $300, $350 for the visit and then whatever the cost of the x-rays are. So I don't know. Even if they're overcharging for the x-rays, I know x-rays are about $50 to $80 usually cash pay. So I was thinking like just double everything.
Right.
So maybe we're at $300, $400, maybe $500 or $600.
Right. What'd they bill?
What was the total? I gave it to you. I think it was like thousands and thousands of dollars,
right? Is this a good time to bring up the slides?
I made slides for you.
Yeah. She came prepared, folks. All right, hold on. Let's see if we could do this. We're gonna have to give my editor something to do in post.
Yeah,
but
just the visits alone. I mean, the one visit was almost $1,000. It was $980 something, I think, and then the second visit was over. They billed for 2 visits, by the way. It was over $800. So just the visits alone you're at $1,800.
Right.
And then I think each of the x-rays were billed at $600 and the other one was over $600.
Well, let's
see.
Let's check it out. So the bill that doesn't add up, and we'll make this available in the show notes. So if you're driving around, we don't want you crashing or anything.
Yeah, don't look at the screen right now.
And it would be nice if my Adobe would cooperate, but it's not. So we're going to try to refresh this. Hold on.
We're going to give it good energy. Come on, Adobe.
Yeah, let's do it. doesn't want to cooperate.
I do want to emphasize, though, that the reason that I'm bringing this to light is because I would love to eventually, somewhere, somehow, start a series where we dissect these bills for people, because I think that it is through transparency and understanding that we will be able to change the system. And I really think that it's important, if there are any employers watching, or if you know employers, you send this to them, because I think that even at the CFO level and the CEO level and the COO level, these things are so far-fetched that that's why they get away with them. I liken it to, and this is a lot of people aren't going to like this when I say this, but I am of Jewish background, and my grandparents were Holocaust survivors, and they always told the story that they couldn't get their siblings to leave town with them and to like get out of there, because it was such a far-fetched idea that Hitler was coming. They had just signed a peace treaty, and they couldn't even envision, like, who would do that? Nobody would put people in concentration camps. Like, it's so far-fetched.
Right.
And so, although this doesn't involve that level of like human degradation, this is so far-fetched, and this is how criminals, I think, get away with things for a long period of time, if what they're doing is just so crazy and out there that the general public is like, this can't even be happening.
Yeah.
So I think that if we just do this one case at a time, this will shed some light. And it is through the employers that we can change the system. If we have about 50% of healthcare being funded more or less by employers, then if they all just start to say no to the non-transparent way, if they start to say no to the price gouging and the price inflation and the corrupt practices, and they find other means, like, you don't have to go head to head, just circumvent, just take a different path. That's the path of least resistance. Then things will start to change naturally, because they're going to have to. We live in a capitalist economy.
100%. And, I think the other thing is, you could trust but verify. And if the scenario that you're painting, though, is really crazy, right? Like not getting out and saying, oh, Hitler's not coming. Right. Or like being that frog in the pot of water saying, oh, water feels fine. What are you talking about?
It's not boiling.
It's good. We're good.
Yeah.
No, and then the next thing you know, you're dinner for somebody.
Yeah.
Right? So the reality is, this stuff is going on. It's happening. Like these nefarious billing practices are called revenue to these organizations.
This is normal. I want people to know this is normal. This is not the abnormal. This is normal. It's just happening in a way that you can't see it most of the time.
Correct.
Yeah.
And any astute business leader, I don't care what the 3-letter, acronym is after your name. You just have to ask yourself, is Dana making sense right now? Is Ray making sense right now? If it sounds like they're making sense, at the very least, verify.
Yeah.
Just do a little homework.
And also, if you don't know about this, it's not your fault. Like, I didn't know about this, and I've been in the system. I had no idea.
Exactly.
And most doctors don't know about this, and they're the ones, quote unquote, submitting the billing.
Precisely.
So they keep us in the dark too.
So let's go to the slide.
Yeah.
And so I don't know if this is not the one. Well, these are the two organizations that were involved, right? Sentara Health and
Williamsburg. So Williamsburg again is contracted by. Am I saying that right? Sentara. Okay.
Yeah.
I want to say Sentara because I speak Spanish and Italian, and I want the short A sound.
I like Santana, but it's not that. It's Sentara. Let's implicate the right organization.
Yeah, and they are a for-profit system. We did look them up.
Okay.
Yeah. So anyway, those are the two groups. Sentara is the facility, and Williamsburg is the actual group that's like providing the care.
And so they billed for a physician who never saw the patient.
So this was the other part of it. So if you go to like one of the core problems, I shouldn't say the core problem, but yes, they actually Sentara billed me for a level. Was it a level? Can you go to the next slide?
You said level 4.
Level 4 visit, right. I think it was. ED visit code. So I can't. Yes, Sentara billed me for a level 3 visit, actually.
Level 3.
And they put a physician's name on there that never actually saw me, and so that was even more interesting. And I called Sentara about this, and I've been on the phone with them multiple times with their billing department, and they're just like, "That's what we do. It's our facility fee." And I'm like, "Yes, but this is a code billed by a physician. That means this is a physician visit code. This is a physician that saw me, but there was no physician that saw me, and." There was a PA from WEPI that saw me, and they're overseen by a physician at WEPI. They're not overseen by you guys. So you should take this off the bill. And the lady was so nice. Like I had a long conversation with her. I was like, I know this. I know you've just been working in the system for so long. We actually had a really nice heart to heart.
Right.
And she couldn't do
She's
anything.
like, it's no my job.
Yeah.
No, and listen, she's not the problem.
No,
right?
She's a single mom actually, and she's been
she's
employed
not-
for 15 years by Sentara, and
She's
she
doing
needs
a
to put
job.
food on the table.
She's doing a job.
Yeah.
It's not her. It's the system. So these are the CPT codes.
Yeah, so I'm going to explain this real fast. So CPT, everything in medicine is billed through CPT codes. Everything. If you don't have a CPT code assigned to it, you're not going to get any money for it.
CPT stands for, do you know? Quiz. It's
Something
CPT.
procedural. Tommy will
You
bring
didn't know
it
there'd
up.
be a test.
Tommy will bring it up. Hold on.
Come on, Jamie.
Current procedural terminology.
Thank you, Spock.
Yeah. Thank you. So the CPT codes for the X-rays, each X-ray has one. If you get an X-ray of the knee, it has one, and if it's a right knee, it has a modifier on it. If it's a left knee, it has a modifier code on
Thousands
it. Like everything's.
upon thousands upon thousands of CPT
They used to
codes.
do this, by the way, with books. You used to
Yes.
have books of CPT codes, and you have to look them up.
Yeah.
And they do this also with diagnoses.
Right.
So if you bill for example, if your visit's shorter time frame, but you have 3 or 4 things that you've addressed,
Yeah.
then that automatically increases the level of the billing that you can put through as well. So
Yeah.
then you add the ICD-10 codes to it, which are diagnosis codes, and there's a book full of them.
Right.
Now, thankfully, with AI, it makes it so much easier. So anyway, elbow X-ray, forearm X-ray, and then there were two ED visit codes. So
These are 4 separate CPT codes. That's what you're showing here.
Yes, that's
this
what was
This
billed.
isn't the level of severity of the ER visit.
Well, they are, because if you can see, the number 3 is a CPT code 99283.
Yeah.
And then the number 4 is a CPT code 99284.
Yes.
And so 884 is should in theory be a more extensive or severe visit than a level 3, the 99283. So they go in 99281, 99282, 99283, 99284,
I see.
99285.
I see.
5 is the max level. That's you coming in needing a stent placed or a bypass.
Okay. And
'Cause you have a
the
heart
0 is just X-rays. It's
all-
not
the
related to
CPT
the ED visit.
Which one?
Well, number 1 and number 2.
Number 1 and 2 are just the
X-ray
X-rays that
codes.
happened in the yeah.
Got it.
And there's a CPT code for, I don't know, a pap smear, a pelvic exam.
Sure. You name it.
Yeah.
You name
It's
it.
a procedure code, basically.
But the crazy thing is there could be a couple of hundred different prices for the same exact CPT code in the same exact hospital.
Yeah, that's called the chargemaster
Yeah.
for people that are listening. And it's really, nobody can really get a hold of the chargemaster. I actually just talked to it. This is a complete side note, and we can talk about this a different time. But I had a nice meeting yesterday with an undergraduate student who is working on a project to actually help hospital systems become more transparent with their chargemasters.
As if that's what they really want.
I know. But it was I told him that. I said it was, but I wanted to encourage him because I thought it was a cool idea.
Yeah.
So he put together this whole software program. He coded it himself.
Okay.
So anyway,
Let's see,
to be continued.
Report back to us
Yeah.
on how that experiment goes. All right.
Yeah.
So what else do we got?
So if you go back to can you go back to
The
the
previous
other slide? Yeah. So I put what they build. So the Sentara build for the elbow X-ray alone, just for it takes 2 seconds. It's like boop, 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 done.
Yep.
$902. They billed for the forearm X-ray $659. This is the bill I'm getting.
Mm-hmm.
And then for the 283 code, which was by a doctor that never saw me, never said hello, nothing, and never walked to the room,
Right.
$982. And then for the physician assistant that's employed through WEPI, $837 for a 5-minute visit.
And this is the cash price,
Yeah.
right? The cash pay price
Yeah.
for this stuff.
Yeah.
Crazy.
Mm-hmm.
And the insurer rates
Yep. So
in
I
this
put
case.
that. So I want to make things clear. I actually I was searching around and I came across a website called payerprice.com. I'm sure there's other websites, but these guys were nice. I talked to them, talked to the CEO, and they were kind enough. They bring price transparency to help systems negotiate their rates with insurers.
Yep.
But they were able to do some digging and they gave this stuff to me for free. to present here. So I got all of this information. The insurer rate is either Blue Cross, United, Cigna, or Aetna. That's what they were looking into for this specific system, or it would have been for Williamsburg and the surrounding areas. Because obviously it's important to know what are these systems by region and by system actually receiving as reimbursement from any of the major insurance companies.
Right.
Because I think that's important information. And then also, what are these systems receiving from Medicare? So there's two categories.
And that's going to vary by geography, plain and simple.
By geography, yes. And also by size of the healthcare system, how much negotiating power they have.
Yep.
Yeah.
Yep.
So so these were the ranges. So for the x-ray that I'm being billed $902, and we know that any major insurance company is reimbursing $26 to $78.
Wow.
I'm being billed $659 for the forearm x-ray, and we know that any major insurer is reimbursing this specific system $25 to $70.
So in this example, the system, if you're calling the system the healthcare provider, they're not gouging here, right? And they're essentially gouging you, right, in terms of the bill that they're presenting to you. In that sense, yes, you're being price gouged. But from their perspective, if this was going through insurance, they're getting peanuts compared to what the insurance company is billing. That money is going straight to the insurance carrier. So the insurance carrier, according to what I'm seeing, is the real villain here, right? You have two villains in the story so far. You have the system itself, and then you have the insurance carrier. In the case of the system, the healthcare system being the villain, you're coming in saying, I'm a cash pay patient. And so they're presenting you with an egregious bill. And in that scenario, they're the only villain in the story because there's no insurance carrier in the story, right?
There's no insurance carrier in the story.
It's you and them.
Yeah.
But what you're exhibiting here for our audience is if someone showed up with an insurance ID card and they came into the system, these bills may still have flown the same way. They may have even inflated the amount that they charge the insurance carrier, but the insurance carrier would only be reimbursed. The health system would only be reimbursed a small fraction of what was actually charged.
Right. Well, what was actually billed? Yes.
What was actually billed.
Yeah.
Yeah.
And there are a lot of instances, and I have another situation to get into maybe a different time, but just I'm in this every single day with patients, right? Patients coming to me saying, why am I getting a bill for $800 for a breast ultrasound, which we talked about?
Yeah.
It was billed at $2,000 when the actual cost of a breast ultrasound is $180 to $280. So why, even with the insurance, why is this patient now having to pay $800?
Yeah.
They're paying a portion of the super inflated, gouging that's happening.
Right.
And part of that also, I think, is just over the years, this is on the facility side or the health system side or the physician side, they're saying we have to say our prices are much higher because then the insurance companies come in and say, we're only paying you a fraction of that.
Right.
So if we say our price is $100, then we're only going to get $1.
Right.
But if we say our price is $1,000, then we'll get $10.
That's completely ass backwards.
Which is, I don't know what's true because I'm not involved in that side, but
yeah,
it's what it is. So.
Yeah.
But I think there's another. If you go to the next,
yeah, let's see what else we got here.
Go to the next slide after this one. Yeah. So this is just another example. You tell me when you're ready.
Yeah, you're good.
Okay. So this is, again, from Payer Price, and they were nice enough to actually get us what United, Cigna, and what Medicare I got from the Medicare data on their website. But they were actually able to get us the exact amount that these claims were coming in at and with the system. So Sentara is actually getting reimbursed $78.44 from United and $68.77 from Cigna for the elbow x-ray.
Okay.
So then why am I being billed $902? Now, I want to put this out there. I did call both systems. I attempted to call both systems. I was able to get a hold of somebody at Sentara a couple times, and they did offer me a 50% discount. That's why I put the 50% discount category up there. I was not able to get a hold of anybody at Williamsburg Emergency Physicians Incorporated. I emailed everyone. You know how tenacious I am. I looked up who is running these organizations. I emailed them. I messaged them on LinkedIn. I called. I couldn't get a hold of anybody at WEPI, which was frustrating because I think it's a physician-owned organization and just nobody was willing to talk to me.
Right.
And nobody higher up at Sentara was willing to talk to me either, which is a little bit frustrating, especially given that I'm writing from, hey, I'm a physician and I want to talk about this.
Right.
So anyway, I just want to put that out there. I didn't just we should just complain about this. I tried.
Why do you think they didn't take your call or get back to you?
I don't know. Who knows? But maybe they will now.
One can speculate.
Maybe they will now.
We can say, well, maybe they call their legal counsel.
Yeah.
And do you think their legal counsel would say,
I messaged their legal counsel too. I did.
Yeah. And you didn't hear back from them?
No.
Uh-huh. Yeah. you know, if you don't hear back from legal counsel, you're onto something.
Yeah.
Right?
Yeah, probably.
Because they have to do the calculus and they have to say, all right, well, if we get back to Dana, what's the potential for a positive outcome for the organization versus a negative outcome for the organization?
And what's the chances that she's going to take this public?
Correct.
I even messaged, I think in my follow-up message, I said, hey, just so you know, I think I'm going to take this, and just talk about this publicly.
No, and you can. You're firmly within your rights. As far as I know, this was your experience with their facilities. You clearly, you didn't reach out once. You didn't reach out twice. You reached out multiple times. You didn't get anywhere. Mm-mm. And, you're a learned physician that's in the game. You understand this far better than most. What's the single mom, working 3 jobs to put a roof over her head to do?
I don't know, but she should be promoted, by the way, Sentara. If anyone in Sentara is listening to this, that woman that I had a conversation with in billing, you need to promote her because she had really good people skills, and she shouldn't just be answering the phones in billing. She should be a manager. So
yeah.
Yeah, I'm serious.
I don't know if you want to shout out her name. Probably not,
so and then I just broke it down. I did the same thing with the forearm X-ray, and then I did the same thing with the actual the visit codes that were billed. So you have the Sentara visit code, which was negotiated down to $441, but then the major insurers pay a range of $61 to $189. Yeah. Medicare reimburses that facility, Sentara, $73.58. Yeah. So then why am I being billed at 17? Is that 17 times? I don't know. I'm not amazing at math. I have to use a calculator still, but yeah, and then the same thing for the level 4 visit. Medicare is reimbursing $125 in this region or to this facility, and the insurers max out of pocket or max that they're getting reimbursed, but the insurers is $296. Yeah. So again, why is my bill $837? Even double that is.
Yeah. Yeah, that's just outlandish.
But this is normal. This is happening every day. That's why, again, I'm fine. I'm whatever.
Knock on wood. Yeah.
Thank. But but imagine the single mom that's not okay.
But let's stay on that for a second because that's a big piece of it, right? You're fine, right? Because what we're talking about is how egregious the economics are. The economics suck, right? It's in black and white. We see what the bill charges. We see what the insurance carrier reimbursement to the facility is. We see what you paid. We see what Medicare paid. The math just doesn't add up, right? It's way too convoluted. But you're okay, right? And it's important in healthcare that we understand that both of those things are important. We shouldn't be raped on the bill and, have a health outcome that is poor. You should be able to have a good health outcome and pay a fair price. And if we're just dwelling and focused on the health outcome, and I think a lot of folks, particularly decision makers, kind of look at healthcare through the same lens that they do anything else that they purchase, you get what you pay for. It is completely not the case in healthcare. In healthcare, you can pay the lowest price. And often the lowest price in healthcare is equated with the highest quality. It sounds preposterous, but that's the truth. Because if you are paying a cash pay price and you're paying, now in your case, it really didn't work out that way. Like you are presented a 50% discount, which is great on that one case. But ultimately, if you are paying a cash price and you can negotiate a rate, and typically the RBP vendors out there, the Imagine 360s of the world, are going to negotiate a fair reimbursement based on that Medicare price as a baseline. And so if you're a CFO out there and you're listening and you're putting on your CFO cap, or whatever executive you are in the chain, if you're involved in purchasing healthcare, know that that's kind of the mechanism that the industry is using. They're taking that Medicare reimbursement as a baseline and typically marking that up 20, 30, 40, 100%, which is still far below the negotiated insurer discount rate and typically even lower than the cash pay price, quote unquote. And the other side of the equation for the finance, cats that are tuning in, is the time to money is typically a lot quicker in a cash pay model. So you're not being strung out for months and months and months while the insurance carrier is playing the float game on your money, right?
Yes, there's that's on average, it's 3 to 6 months, if not longer. But I have a question for you. So if I were an employee of a self-funded organization, let's say I'm organization A, I'm large enough that I have a self-funded insurance plan, and I'm using Blue Cross, or let's use Cigna, as my administrator.
Mm-hmm.
Is it true that I as the company am going to get this bill, because I'm still paying for everything, but am I getting the inflated cost of the bill? Am I getting the $902 for the X-ray bill? Or how does that work with Cigna as the third-party administrator? Is there some sort of discount that's negotiated? I feel like it, yeah.
What does the Kool-Aid guys say? Oh, yeah.
I think so. Something along those lines.
Yeah. You're paying the maximum that you can possibly pay because you're in an ASO arrangement, administrative services only organization, which means that Cigna, in your example, is the TPA. They're the third-party administrator. So they're adjudicating the claims. What does that mean? Adjudication. Ooh, sounds crazy, right? Or, I heard, Tommy over here say that he's a CPA. What do CPAs do? They count beans. They look at bills.
My bean counter.
Exactly. No, but the point is, you don't. Tommy, do you pay a bill without looking at it? Would you say that's a good accounting practice?
He doesn't even go to the grocery store without looking at costs. He's like, "What does that cost?" And I don't know. And he looks at me and laughs.
There you go. So that is what Cigna is doing as an ASO in that example.
So when let's break this down. So when I'm employer A, my employee just went to the ER, and this bill of $902 for the elbow X-ray comes through Cigna.
Yeah.
And does anything happen to it, or it just gets is the bill?
So they have a negotiated arrangement with Sentara Hospital.
Okay.
And it says we will pay 80% of bill charges, and that's the negotiated. And maybe it's better than that. Maybe it's 60%, maybe it's 50%.
But you don't. But they already have that. Like, you as the employer are relying on them to negotiate down these ridiculously inflated prices, but they're never getting down to the actual rates that they're paying for their fully insured plans.
No. So
but maybe it's
what I tell people is, just use an example that you can that's kind of every day, right? So retail wholesale. You're paying retail prices when you're doing business, even with a self-funded plan. If United is the TPA, if Cigna is the TPA, if Aetna is the TPA, you're paying the most that you could possibly pay. You're paying full retail, right? And then if you don't have any cost containment and you're also relying on those organizations to take care of your PBM, they are your pharmacy benefit manager as well. So your drugs is put through their
processing system.
That business unit in their organization, you are absolutely paying the most that you can possibly pay. So yes, in this example,
you're not getting that $68 Cigna rate that Cigna's paying on a fully insured plan. You're getting maybe a maybe you're getting the 50% discount, so you're still paying $451.
They're making money with both hands.
Because they're making money. Is it this true as well? The Cigna will make money in their contract. It's written that if we get a certain percentage of the discount that we negotiate for you.
Mm-hmm.
So obviously it's more important for them to have that initial amount come through higher and then say, hey, we negotiated a large discount for you.
Correct.
Right.
Correct. It's a big shell game.
Yeah.
And so, what do? You stop doing business with those folks.
Right.
Right. So you go to an independent TPA that, and the terminology in the business and the game is auto adjudication, right? These large insurance carrier ASOs are auto adjudicating the majority of claims, meaning they're blindly paying the claims as they come in. If you have I'm gonna use I don't want to use the word fiduciary, but if you have an independent TPA that is a good TPA,
They call it ethical capitalism.
Okay, let's use that. Ethical capitalism. They're in your corner. They're looking to maximize the savings for the plan sponsor, which is the employer, and the plan members. Right? That's what you need. And
Right.
so they have different thresholds. So even they will employ some auto adjudication just for efficiency, but they'll have buckets. Okay, any claim that comes in that's above $2,000, we're going to put an eye on it. Any XYZ claim that comes in over $5,000, we're going to put eyes on it. And you catch stuff because you're looking.
Yep.
And when you look and you catch stuff, guess what happens? You end up being able to negotiate and save.
So I have a proposal for if you're a CEO or an HR person. Because I actually learned about this process. We were at a conference for Murphy Business for Tommy, and I met a really cool guy who's what were they? Electrical Workers Union? Yeah, they were the Electrical Workers Union, and they have I think it's a $500 million fund that they're running for
Like Local 3? One of the other, there are a bunch of them.
I don't know, but they have the huge operation they're running for all these electrical workers that can be part of this union, and then they've for their benefits. And he said he didn't know anything about direct primary care yet, but he said that the first step was I think it was with Blue Cross. They said, hey, we want to bring in our own person to audit the claims that are coming through to see if they're reasonable.
Mm-hmm.
And they wouldn't let them do it.
Okay.
So they're still actually using United, which is interesting. But apparently in their situation, United is allowing them to use their own independent auditor who they hired internally within their fund to audit. So that could be an interesting exercise to just, if you are running an employer-sponsored health plan and you're using Blue Cross, United, Cigna, or Aetna, go to them and say, hey, we want to bring in our own auditor to audit the claims to see if they're reasonable.
Yeah.
And if they say no or push back, then you sort of have your answer, don't you?
Pretty much. Yeah.
I mean, that's just step one. I like to break things down into baby steps, because that whole concept of just get off the plan and circumvent it, that's overwhelming, especially even for a company of 200 employees.
Right.
It's overwhelming.
There are ways to do it, but typically anytime you challenge the status quo and you recommend navigating away from an ASO arrangement where the carrier is also acting as the TPA, or bringing in an independent, third party to conduct an audit, you're always going to get pushback.
Right.
And the reason is they know that they're going to find bad shit.
Yeah. Well, even if they don't find bad, let's even take the judgment out of it. Even if they don't find it bad, just get a list of this is what I ask employers when I talk to them to do. Just do me a favor. Just get a list of how much money was spent in the following categories: imaging, radiology. Let's just see the claims.
Yep.
And I can show you what those things cost self-pay if you were to use a different arrangement and make some of this stuff self-pay, or it would, a different third-party administrator could maneuver that, paying out the claims a different way. And then you can make your own comparisons. Just do an apples-to-apples comparison, and that's where the transparency comes.
You're going to find bad shit.
You're going to find
And you know what? You shouldn't have a problem.
It's okay.
You shouldn't have a problem with doing that dive with that. Dispel what I just said. Prove me wrong.
Yeah.
At least then you could say, okay, we went through the exercise. We didn't believe that Ray was right, and we found out that Ray wasn't right.
That's fine. You're
Email
okay with
me,
being wrong.
Send me communications.
We're both okay with being wrong.
I want to hear it, But the truth is, it's a $5 trillion ecosystem with a T.
Mm-hmm.
There's a lot of waste, fraud, and abuse going on.
And we find that some of the holdup is when I've had these conversations with employers before, and then I think the employers will go back and talk to their friends who are maybe like the traditional brokers, and again, they're not evil, and then they're like, no, it would be dangerous for you.
Yeah.
It would be very, very dangerous for you to get off of traditional insurance. You'll go bankrupt if you do that.
Sure.
And then they don't present them with any other options. And this happens on the golf course. Like,
yeah.
I don't love to golf. I'd rather, if you want to, like, let's go play volleyball. We'll talk about this stuff. Right? But I'm not usually the one that's having the time to golf.
Right.
This happens on the golf course after I have these conversations, and then the conversation ends. And it's like, okay, well, just do this exercise on your own. You don't need anybody. Just get the I'm just encouraging you to get the information, step one.
Yeah.
So.
No, and we're working on some stuff behind the scenes that will be readily available, certainly by the time I think we air our conversation, where an employer is going to be able to just arm with two things: their annual cost and the number of participating employees. Will present them with some numbers that will really open up their eyes. And that's really all you need, just as a baseline. And then if they want to go further than that, we're going to provide some tools to really do a deep dive and make this stuff real. Because part of the problem is it's so abstract, right? Insurance is an intangible. You don't go to a supermarket and, pick up, if I send you to the supermarket and I say, go get Tide, and, make it have that, whatever it is, that HE symbol on it so it works in my washer, and I want the one with Downy. I give you specific instructions. You could zero in and pick that sucker off the shelf, go check it out, bring it back, and we know that we're good, right? Insurance is abstract and it's intangible. So I can't say this is specifically exactly what you're going to get and just have that be the thing, right? Unfortunately, it doesn't work that way. It's designed to be confusing, right? People don't even understand how to, use the coverage that they have in a traditional system. They don't know the difference between a copay and a deductible.
It's confusing for me.
Thank you very much.
They're so different. It's confusing for me. If I don't know how anybody gets this, and I'm living in the system.
And you're brilliant. You're friggin' how many languages do you speak?
I speak 3.
3. Well, I speak good. 1 poorly.
Va bene. Possiamo cominciare con un po' di italiano.
You see? You see what I mean? So, yeah, the reality is it's confusing by design. And the idea of our little show is to hopefully, cut through some of that muck and mire, right? That's what we're here to do. Any other slides that you wanted to touch on here?
I don't know. Let's go through. I think that really exposes the. I think it's important to note that this doesn't just happen to people who are, quote, uninsured, right? And I wouldn't consider myself uninsured. I have my backup plan in place. I always encourage people, by the way, to not go completely bare. If you are completely bare, at minimum, see if you would qualify for signing up for a health sharing plan to start with. Like, just because it's the bare issue where if something big happens, but this could happen to you if you go into the emergency room and you are seen by an out-of-network physician. You don't have any control. The last thing that you're asking when you're in pain from a kidney stone is this urologist who you're consulting with gonna be in network? Like, nobody asks that, right? And so this could happen in that situation where they're out of network and then you're getting the full inflated bill.
Right.
I shouldn't even say the full bill. It's just the grossly unethically inflated bill. And it could happen if, your insurance denies a claim as well. When they deny a claim, you're not getting the negotiated rate, you're getting the inflated claim.
Right.
The other thing is that there's a great organization called goodbill.com. And I think that's important to note that a lot of these organizations that are masquerading as nonprofits they're still nonprofits. So they I forget what the rule is called, but there's a law in place where they should be giving certain discounts based off of income. So you should always call and talk to them. Now, I want to just throw this out there. I put in hours of work on the phone. And I just want to acknowledge that, man, people are busy. You have lives, you have children. This is a lot. This is a lot of work to do.
Yeah.
But so I'll leave that there, but you should always call and inquire. And the first step is make sure you're getting a full bill with all of the CPT codes and everything on there so that you have all of the information. And
while you say that, I would also say that, the late, great Marshall Allen wrote a book called Never Pay the First Bill. And he was a consumer advocate. And so there are resources out there where, and these so-called, charitable nonprofits that are often faith-based will come after you and your children if you owe them money. And so Never Pay the First Bill is really about understanding what your rights are as a patient. And if you're someone that is kind of under the weight of medical debt, and medical debt is over 100 million Americans, believe it or not, carry some form of medical debt. And on average, it's over $10,000 of medical debt. And so if you can, just kind of wrap your head around that number for a moment, that's a huge, huge number and a massive amount of people. And, I think the inclination is let's just pay the bill and move on with our life. But some folks just can't afford it. And it's the number one cause of bankruptcy in the U.S. So there are resources about there. Marshall Allen, Never Pay the First Bill. I highly recommend that.
You had a guy on your podcast that I listened to, and I actually did a little short explanation video on my Instagram channel. I'll put a little plug at Dr.Dana Love Health.
Cool.
But it's just I did a summary that if you go to the emergency room, if you're not unconscious.
The great Al Lewis.
Yes, Al Lewis. If you're not unconscious or if you have someone that's taking you, just share this with everyone that you can. Do not sign that electronic form. Make them bring it to you in paper.
Correct.
And then he has specific language that he'll have you cross out, like the clause that says, I'll pay whatever, and put the specific language in there. So it's important. Go search for Al Lewis with the validation.
Al Lewis is now running the Validation Institute and also Quizify. Harvard-trained attorney, taught economics at Harvard. Lost at Final Jeopardy on a math problem, but that's another story entirely. You have to tune into the episode for that. I love you, Al. But brilliant guy. And ultimately, he came up with something called prevent consent. And when you go to the ER, there are typically two releases that you're required to sign. One is a release that says you can treat me medically. Got to sign that one. The other one is you're personally liable financially for anything that happens in the ER, and you don't have to sign that one. And the prevent consent basically gives you language so that you can strike out their language, write in language, which basically says that you agree and consent to reasonable charges up to 2 times the amount of Medicare that Medicare would pay, including insurance. And, I'm paraphrasing. You get the exact language if you go to the link and sign that. And listen, at the end of the day, it's not that you're going to be bankrupt from that emergency visit, but it's about knowing your rights and heading it off at the pass. Right? You want to get ahead of it. And so the prevent consent really goes a long way at tilting the cards in your favor. And so they must treat you, it's law, they can't kick you to the curb. And if you don't sign their release, even if they don't accept what you write in, at the very least, if you show up in court and they don't have your written consent, then you have a leg to stand on and say, this is just outrageous.
Right.
And a judge can look at that then and say, and make a reasonable and fair judgment, hopefully.
Yeah, and they have to treat you. There's a law called EMTALA. And they have to treat you. No matter whether you pay, they can't expect payment up front. Even if you cross it out and they're like, the hospital administrator comes down, they're like, you can't do that. You have to sign this form. You can say, actually, just cite EMTALA. You're required, and start filming. Maybe.
If you say EMTALA, it's
Yeah.
like, you ever watch The Lion King and the hyenas say Mufasa? It's like that. They lose their shit.
Yeah.
They're like, ooh, say EMTALA.
Tail between the legs.
Emergency medical treatment and active labor law.
There you go.
EMTALA. You say
Yeah.
that, and they'll magically change their tune. If they
Yeah.
don't, they're stupid, because
Yeah.
they should be scared of EMTALA.
Yeah, so you should share this with anyone and everyone that you know, because if something horrible happens and somebody's taking you, somebody else is going to need to sign those forms probably for you. So
Correct.
yeah.
I think we get off the slides. We're going to have the slide deck that you tirelessly put together as a link in the download. But I think the moral of the story and the punchline is, you don't have to take it as a patient. Like, you had a slip and fall on the ice, you were overbilled, and you're in the know. And even after making the calls and putting in the work, they didn't really make any adjustments for you.
And I don't know that they're outside of their legal scope. I think that we need more legislation around this in terms of putting some regulations on, the fairness, the fair billing practices. So I'm not accusing anyone of, being outside of the legal scope. I think that, again, it is through knowledge that we can transform things. So I think this is just step one, and just putting the knowledge out there.
But in your case, Dana, you had Zion. Did Zion step in and pay them? Has it been settled?
I wrote to Zion, and then I tried to get to the CEO at Zion, and I was like, I don't think you should pay this. In fact, we should tag them on this.
Yeah.
I don't think you should pay this. I also don't think that you should pay. The one thing that I think was legally inappropriate was that they billed me for a physician that never saw me. The physician assistant visit was fine, but Sentara shouldn't be billing me a level 3 visit for a physician that never saw me. But they wouldn't respond to me. So
because that shit happens all the time.
Yeah.
I have a personal friend who's also a client. They run a good sized organization, and she had a hospital stay, and the same exact thing happened. Because she reviews her bills, and she said, "I never saw this guy. This guy never saw me," and I don't know what happened, but I know this: she got them to strike it off the bill because she was not going to tolerate anything less. And she knew that she was in the right, and she was.
Right.
And so, it would have been interesting to see what would have happened had Zion not paid. And then this gets elevated, and maybe, it goes to collections, and it gets in front of a judge. And, if you watch the episode with Al, the most recent one, he does have a scenario, and I'm not even sure how that played out, because then the problem becomes, we transition from the broken healthcare system to the broken legal system, and then it's a whole other kind of
This is the bottom line: is if you are an employer, you have the capacity to change this for all of your employees.
Yeah.
This is step one, and I think that we're still small with our other companies, but we are already committed to making it happen, because we've been given an opportunity to make a change, and we need to make that change. So if 40% or half of all of the employers make the change, that's going to cause significant economic hardship and change on the side of the health insurance cartels, and something's going to start to shift, right? So I think that's the bottom line.
Well, so I think businesses are starting to kind of get it, right? So the ginormous businesses that are self-insured, like if you think the Amazons, the Googles, they're managing this already, to a pretty good degree. I shouldn't even say that.
Sort of, not really though, because they're not. We have a couple employers that are large like that.
Yeah.
And they don't seem to care to use us for cost navigation at all.
Yeah.
It's like it amazes me. And their employee, I just gave you that situation where their employee got a bill for $800 for a breast ultrasound when we know the actual cost is $180 to $280 locally.
Right.
So why is that happening with a large self-funded employer.
Yeah.
That's a worldwide employer, by the way.
Yeah, and the answer, unfortunately, is it's budget dust to them, right? It's just they're so big that even saving $1 billion is like not a big deal, which is crazy, right? It's crazy, but that's the case. Typically we find, and brokers listening in can relate, the best targets are the targets that kind of operate on razor thin margins, because every dollar saved there is an exponential win for them, right? If I can save a company $10 million over 10 years and they're working at a 10% profit margin, they have to generate $100 million in business to recognize $10 million in bottom line savings, right? And so if it's a 50% margin or an 80% margin, it doesn't become as compelling. If you talk to a private equity firm that understands the numbers and they know that business has also got a PE of 20 or 30 or 50, you have their attention, because now you're creating enterprise value that's what they're all about. And so I think that, we just need smarter leadership, whether it's an HR executive or someone on the finance team or the CFO that can look at this and say, healthcare is our second or third largest expense after payroll. And if we manage it properly, we can do wonders for our bottom line and our shareholders. Crunch the numbers, do the math. I promise you can do wonders for your bottom line and your shareholders. Once that message starts getting out, then it takes it just changes the conversation. The golf buddy at the country club, you can make new friends if you have to, right? Ultimately, if we're talking about $100 million to your organization, that's a lot of Masters tournaments that you'd have to kind of, foot the bill for. And I hate to say that, right? That sounds really kind of low budget, but I really believe in my heart of hearts, a lot of these relationships are created where there's some sort of payola going on, or it just makes it so easy to turn a blind eye. But at the end of the day, you have a fiduciary obligation to your shareholders. This is an easy way for you to put eyes on it and say, are we doing the best we can do? And if the answer is yes, great. Take that litmus test, right? Take that leap. If you're doing everything that you could possibly be doing, then you should be able to just kind of run that through an audit every couple of years, just as a self-analysis, as a self-check. And you might be surprised, though. You might find an opportunity where you could save 10%, 20%, 50% on your second or third largest P&L expense. That's significant.
And also, I think just recognizing that a lot of alternative means to fund healthcare, because they're transparent, mean that you're not going to be getting 7 to 10% automatic premium hikes every year. So that's just step one, is like ask yourself as well, what if our employee population is relatively healthy? A lot of companies have a pretty young employee base.
Yeah.
What if they are pretty healthy? Why are we getting these hikes? If we're not, we don't even know how much we're spending of the total premiums that have been paid in. How much of those premiums were spent and on what?
Right.
And if you're not overspending on your premiums and you're actually saving money, then why are you getting an increase?
100%. And
the basics.
And then the other side of the coin. Well, let me ask you, how long does your average patient in your practice, how long does it take for them to have a conversation with you over the phone or get an appointment?
Oh, we're same or next day for urgent appointments. Like, we make sure that we see everybody. I mean, step one.
Same or next day.
Everyone has our cell phone numbers. They know they can just get a hold of it. We don't want anybody going to the urgent care if we can avoid that.
Right. And then once they see you, if they need a major diagnostic exam, are you sending them to the local hospital?
No, I mean, it really depends. I know we do. So DPC is a core piece here. I think that if any employer, and you've been in the space a lot longer than me in the brokerage space, but
yeah.
I think that if you're thinking about an alternative type of plan where you're going more self-funded or level funded, I think you need to have a DPC, a direct primary care doctor, that does cost and care navigation. Because if you just simply go self-funded, but you're still using the traditional means, right? Like I know purposefully I will not send to the health systems whenever I can avoid that, because I know Dr. Eric owns Wisteria Imaging, a great imaging center down the road, and I know that he has full transparency with his offerings and the cost, and I know that they're going to get quality care there, and I know that if something comes up, he's going to call my cell phone number, right? So I try my hardest and to have any employee that we hire, like our nurse practitioner, practices the same way, where we have an internal list of who we can refer to, who we know is a quality care provider and also provides transparent pricing.
And that's huge, Dana, because at the end of the day, it's not uncommon for us to see a 10x differential in what the bill charge is at the hospital versus a freestanding radiological facility.
That's normal. At this point I expect it, because I see these patients are coming to me. They're bringing their bills to me, and I'm just. And this is why
You're aghast.
Well, I've now just come to say, yeah, this is normal. So even now, for patients that I know are coming from self-funded larger employers to us, I tell them, I say, listen, I have all of the self-pay just for labs. I know exactly what all of this is going to cost you if we go through Quest or some other self-pay option that I have. They're in the system. I can just bring it. I can just make the lab list. So you need to really figure out on your specific plan, do labs count toward your deductible? Because if they do and you haven't met your deductible, right? And a vitamin D is going to be billed at $200, whereas it's $15. That's the actual cost. It's not a discounted cost. That's the actual cost of a vitamin D. Expect a 10 to 20% markup on everything.
Right.
So if it's covered, fully financially covered, and I also explain that like financially covered is different than approved.
Right.
Right. Like I can get an authorization for an MRI. That means nothing about financial coverage.
Right.
It just means that they're authorizing it to happen, and then you have to sift through the fine print.
Yeah.
So I just encourage everyone to get very cushy with whatever plans they have. And then when they're ready to have that discussion about alternative funding, it's not for everyone.
Right.
But it's an important discussion to have, because I liken it to malpractice when it's not had.
Yeah.
Right. If you come to me and you have pain and I don't say, hey, this is my thought. These are all of the possible things that it could be. And these are all of the possible things that we could do. And I'm ruling out this and this. And that's sort of, to me, that's malpractice, because I'm not providing you with all of the information that you should have.
Yeah. No, 100%. And what I was getting at earlier, though, is in a traditional model, it's not uncommon for it to take 3 months to get an appointment with a primary care physician. And then if they need a specialist, another 8 months.
Yeah, that doesn't happen.
And so in your practice, you're seen, and unlike the traditional model where you may wait around in the waiting room for 2 hours only to be seen by your physician for 15 minutes, it's kind of flipped, right?
Yeah, that doesn't happen. We don't schedule any follow-ups for less than 15 minutes unless it's an urgent appointment that's coming in. We're squeezing you in.
Right.
Like that's a different story. Just come in. We got to just see, do we need to get an x-ray or what's happening?
Right.
And, I only have like 10 minutes or 15 minutes, but even half an hour appointments feel short to us.
Yeah.
So when you're scheduling appropriate time for each patient, then you don't run behind and disrespect the patient's time so much. I mean, maybe it's 15 minutes occasionally that I'm running a little bit late.
Yeah.
But
yeah,
and you have time for every patient, and you're not, the traditional model health care providers have 2,500 to 3,000 patients that are assigned to one provider, one clinician.
It's no wonder that they're stressed out and that suicide rates are as high as they are amongst physicians.
Yeah, I don't even know how you manage that. You can't manage it. So part of the issue is that nurses are now responding to messages. So triage nurses, and they're trained as best as possible, but there's a different situation
Different
there.
skill set, of course.
And if they're not, then the doctors are just completely overwhelmed, and you could be waiting for weeks for a response, because if you could imagine how many of the 2,500 to 3,000 patients forgot something and they're messaging about something.
Right.
And it's an impossible system that they're making work.
Well, hey, listen, we could talk for another, we've been going at it for over 2 hours or about 2 hours. Yeah. We could easily do another 2, but that'll just be a reason to have you back again.
Wonderful.
What is the name of your practice?
Love Health Direct Primary Care.
Love Health Direct Primary Care.
Yeah, we have locations in Fort Washington and Doylestown, Pennsylvania.
Okay. And is there a website to visit, or how do people find you?
Easy peasy. LoveHealthDPC.com.
LoveHealthDPC.com. Simple.
Simple. Yeah.
Okay. And I guess that would certainly be the best way for folks to reach out through the website. They can get you.
100%. We're all over Google. Apparently, people are finding us now via like Claude and ChatGPT,
really?
which I thought's cool. Yeah,
That
and they
is
can
cool.
schedule meet and greets. We have old school, new school communication. You can simply call the office, and Valeria is our main assistant, and she'll likely answer the phone. If she doesn't, she'll get right back to
A
you.
real
She's on-
person?
A real person.
Wow,
Isn't that
scary.
amazing?
And
No AI.
And just to kind of bring people up to speed who are not, it's kind of like Netflix meets doctors, right? They're gonna sign up for a monthly subscription, and that's gonna give them access to you as their physician.
Yeah, so we don't own people. That's step one.
Okay.
So we don't have any contracts.
Right.
Yeah. So like when people join, they just have their monthly fee, and I always tell them, you can try our services. If it's not working for you, no hard feelings. Like this is your one time in this, no matter whether or not you believe in reincarnation.
Yeah.
This is your one opportunity in this body, in this lifetime, to go through and be the best you can. So
Right.
if you feel like our services aren't working, we would love to know why. And so maybe we can correct it. And if it's just not working, that's fine. You should go elsewhere, and we'll gladly send you records, whatever you need.
How's your batting average? How many people?
So my panel is full.
It's full.
My panel is full, and Chloe is our new clinician, and she started in January, so she's taking new patients, and I'm committed as we keep growing. I'm just going to continue to hire clinicians that are awesome, meaning clinicians that respect the sacred humanity and autonomy of the person in front of them. That's utmost importance, meaning no patient should ever come into our office and feel degraded, feel like we are relating to them as less than we are.
Mm-hmm.
We're here as humbled advisors. And, if you want us to make a decision for you after we discuss things, that's fine. We'll do it. But if you don't agree with our suggestions, it's okay. I respect you deeply as a human, right?
Yeah.
And then the second aspect is only hiring clinicians that really understand the limitations of Western medicine and that are willing to dig in and do a little bit more integrative, and learn about. We need them to understand hormone replacement therapy. That's really important. But we also need them to understand that there may be other ways than like, here's your standard antibiotic,
Yeah.
Hey, maybe like a combination, or maybe black seed oil. Let's look into that. Providers that are willing to grow, they have an open mindset, and they're willing to say, I don't know the answer to that right now. Can I get back to you?
Right.
Yeah.
Interesting. Yeah. So, again, folks, if you're not informed, learn about DPC, because I really believe that DPC, it's certainly not the answer, but I think it's a huge component of what the new healthcare economy can look like. I really believe in DPC, particularly if you find a provider that you connect with, they connect with you. If they're of the mindset that Dr. Mincer is of, and they're looking at you as a human being, as the whole enchilada that you are, they're taking a holistic approach, and they're not concerned about, writing a script to get you to the hospital system that they're affiliated with so that they could earn RVUs, which has transformed our doctors into glorified salespeople.
Yeah, we don't pay based off of our
She's not part of that.
Yeah.
But it is a thing. You can look it up. I applaud you for what you do. I hope that you inspire more physicians to go down the rabbit hole that you went through, because it's not an easy decision doing what you did. It's courageous.
Yeah, they don't need to. That's the thing. Like, we've just created an employment opportunity, which is awesome. I was able to do what I did because I have Tommy. I'm very honest with people. I don't know that I would have been able to do it without him.
Right.
It's a lot of work starting a company. You really need a solid foundation. And, he's already an entrepreneur. He's a CPA. Like, he helps me tremendously.
Sure. It's a business. You're not taught, you're not taught to be an MBA.
It's a baby. It's another baby.
Yeah.
It's like, it's constant. And so I had him to help with some of that load. I have him to help with some of that load. And so we understand that it's just not, entrepreneurship is not for everyone.
Yeah.
And that's why we just said we're committed to growing. So if we find other like-minded providers, hey, call us up, send us a message.
Right on. Yeah.
So,
All right. So we'll get some stuff in the show notes so people can find you.
You can take my whole presentation if you want it, or I can clean it up however you want.
Whatever you're willing to share.
Yeah.
Makes no difference to
Full
us.
transparency here.
100%. All right, folks. Until next time, love always. We'll see you on the next one. Take care.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.